We're going to take a little break from rhythms right now and talk about single ventricle congenital heart disease. I do have a disclosure, and that is that I'm a consultant for Philips Ultrasound. I teach their fetal echo course. So what we'll be discussing in this lecture is to have an overview of single ventricles, talk about the surgeries for them, talk about cyanotic congenital heart disease with single ventricle, classic single ventricle, and then low output congenital heart disease with single ventricle. And lastly, when two ventricles don't really equal a biventricular repair. This is a little bit of a hard topic to talk about because we've already talked about hypoplastic left heart and hypoplastic right heart, so there will be by necessity some review, but they always say repetition is the mother of learning. So never turn down an opportunity to learn, I guess. So if you look at the data, functional single ventricles represent about 8% of all congenital heart disease. The classic single ventricles we've already talked about, except for the double inlet left ventricle with a small outlet chamber. But there's also a very specific type of single ventricle disease where you actually have two ventricles, but because of various factors, those two ventricles don't end up having a biventricular repair for the patients. And those include severe neonatal mitral stenosis, severe Ebstein's anomaly, as we saw from Dr. Polchowski's talk, critical aortic stenosis with severe endocardiofibroelastosis of the left ventricle, a double outlet right ventricle with a large uncommitted VSD, and double outlet with mitral atresia. And we'll go through some of those examples a little bit later. I like to divide the single ventricles into two really major categories, those that have obstructed pulmonary flow, which is because of pulmonary atresia or pulmonary stenosis, or those with left outflow obstruction and decreased systemic outflow. But as you can see, there are other causes as well that can lead to either diagnosis of cyanosis or of low output. So the surgeries that we use for single ventricle have been talked about briefly, but I just wanted to present the people who were really behind these surgeries. I think one of the reasons I went into pediatric cardiology was there was a certain romanticism about it. These people who were dealing with really sick babies who would die, and they'd have a discussion over coffee and draw diagrams altering plumbing in the heart while they were having coffee on their napkins. And all these surgeries resulted. So the Blalock-Taussig shunt is one of the very first congenital heart surgeries that occurred, and it was really the brainchild of Helen Taussig and Alfred Blalock, who you see here. But the real unspoken person who really did most of the experiments was a gentleman by the name of Vivian Thomas, and he was finally recognized as being a contributor to this field very recently. And if you're ever looking for a good movie to inspire you, something the good Lord made is the story of these three and how they had such a tremendous impact on our history. So the Blalock-Taussig shunt basically is the interposition of usually a Gore-Tex graft in between the subclavian vessel and the right pulmonary artery. And of course, what happens then in these babies who have severe stenosis of the pulmonary arteries and cyanotic congenital heart disease is that the oxygenated blood flow from the left ventricle goes out the aorta, but a portion of it goes into the right pulmonary artery and also then the left pulmonary artery, supplying an adequate pulmonary blood flow. The second step in a single ventricle palliation is when you is the Glenn shunt. But what I was talking about here was if you have cyanotic congenital heart disease, if you have a single right ventricle or a situation where you have decreased systemic output, then one has to provide blood flow to the body. And that was really something that was pioneered by William Norwood, who you see here. And he used the Sano shunt, which is seen right here, right here. This was a conduit that went from the right ventricle into the pulmonary arteries, or he used a Blalock-Taussig shunt, and this is Dr. Sano here, who really started using this shunt in 2003. The last two steps are the bidirectional Glenn and the Fontan procedure. This is Dr. Glenn and Dr. Fontan here. Dr. Fontan just passed away last year. And the idea of the bidirectional Glenn is to gradually unload the ventricle so you are bypassing the heart completely and blood flows directly from the superior vena cava into the pulmonary arteries. And we know that over time and with reduced pressure in the pulmonary arteries, it is possible to have a vein go to an artery without backing up. The last part, of course, is the extracardiac Fontan. There's been different variations of it, but the idea is then that the cyanotic blood from the lower body passes from the IVC and goes directly into the pulmonary arteries, again bypassing the heart as the pump. So the heart, whether it's a right ventricle or a solitary left ventricle, will pump directly to the body, and the pulmonary blood flow will go directly from the veins into the pulmonary arteries. So when you have a situation of pulmonary obstruction, your common feature is going to be you have a reverse ductal shunt. So rather than the duct is flowing the usual way, it goes from the aorta into the pulmonary arteries. And we see here in this fetus with a very small right ventricle here and a normal sized left ventricle, this is the aorta here. You can see this red flow coming from the underside of the ductus and going into the pulmonary artery. This is really the hallmark of significant pulmonary obstruction. Here's another view with a side-by-side comparison showing the aortic arch and the ductal ampulla here. And you can see the flow going into the pulmonary arteries from the ductus. So a reverse ductal shunt, a cyanotic ductus, it's very, very typical. And once you see them, you don't really forget them. So one of the most important defects that causes cyanosis, that is a single ventricle defect, was already spoken about, but just to review, tricuspid atresia is marked by the plate-like atelectasis of the tricuspid valve, and there is most often a good-sized VSD. It is a rare condition occurring in less than 4 out of 100,000 births. The male gender predominates, and it's usually associated with a normal karyotype. Interestingly, there's a 5-fold risk of these babies being small for gestational age, which seems to be a fairly common theme for fetuses with single ventricle disease, and it may be, there's now data coming out, that this may have to do with abnormalities of the placenta that actually are responsible for this. There is an imperforate tricuspid valve, as we've said, and about 80%, so the vast majority, will have normally related great vessels. That is, the pulmonary artery comes from the right ventricle and the aorta from the left ventricle. The entire cardiac output has to cross the patent foramen ovale, which is usually good size, thank goodness. And the VSD, the size of the VSD, is going to correlate with the size of the great vessel that comes from that ventricle, usually the pulmonary artery. So here's what a 4-chamber view of tricuspid atresia looks like. We have our left ventricle here, our good-sized VSD here, and our hypoplastic right ventricle here. As you complete the sweep to see where the vessels are coming from, here's our LV, our RV. We have the aorta coming from the left, and then the branching of the pulmonary artery coming from the hypoplastic right ventricle. But because this VSD is such good size, this is a nice, well-developed pulmonary artery, and the baby ended up not needing anything immediately after birth. You can also have tricuspid atresia with transposition. Here's our left ventricle, here's our right ventricle, here's our VSD, and then we see one big vessel here, which is the pulmonary artery, and the aorta is this tiny vessel here coming from the hypoplastic right-sided right ventricle. Here's another view showing the branching of the pulmonary artery, and again, the small aorta. I always remind people, never trust a fetus. You really need to look at the AV and the VA connections, because the right ventricle does not always beget the pulmonary artery. This is an interesting fetus that had tricuspid atresia but had an intact ventricular septum. So this is the left ventricle here, the right ventricle is here. You can see all this endocardial fibroelastosis here. There is a little bit of a tricuspid valve, but there was no flow coming in, and there was a large effusion later on in gestation. This is what this looked like, and you can see that tricuspid atresia has really developed, but there is really no VSD seen in this view. So turning now to pulmonary atresia and intact ventricular septum, the big difference between tricuspid atresia is you do have a patent tricuspid valve and the septum is intact. This is also rare. There's a high termination of pregnancy rates if you look at the literature. The reoccurrence and association with chromosome and non-cardiac abnormalities is very uncommon. There's variable hypoplasia of the right side. Sometimes it's more pronounced in the right ventricle or the tricuspid valve or the right ventricular outflow tract, and that's because of the tripartite nature of the right ventricle, which we'll discuss in a minute. The great vessels are almost without exception normally related. There is pulmonary atresia because there's no way for blood to get into this right ventricle, so the vessel that comes from that is going to be atretic. There's no VSD, there's the cyanotic ductus, and we also heard this morning about the coronary abnormalities that usually accompany this defect. This is a quote from the 1700s describing pulmonary atresia and intact ventricular septum before angiography, echo, and well before prenatal diagnosis, but I think it's really a wonderful description. The pulmonary artery was found entirely impervious, the septum of the ventricles was entire, and the right ventricle had scarcely any cavity left. The foramen ovale continued open, and the branched pulmonary arteries received their supply of blood from the aorta through the median of the arterial duct. It's too bad nobody writes like that anymore, but they don't. So we talked a little bit about the tripartite right ventricle. So there are three parts to the right ventricle, and the first is the inflow tract, and that's really related to the size of the tricuspid valve. There's also the body, or the apex of the right ventricle, and then the infundibulum, or the outflow portion. And you can see that there are in these pictures here, and again, Norman would be proud of both Julia and me, showing the difference in the types. So this is severe obstruction of the inlet cavity, or the right here, this inflow tract here. This is severe obstruction of the body here, and then this is the imperforate valve of the pulmonary artery. So you can have different degrees of narrowing based on this picture. You can also see this pretty early in gestation, not as early as Elena showed us at 12 weeks, but this is a 15-week fetus here who has a normal left ventricle, a very hypertrophied and hypoplastic right ventricle. You can see the aorta with its branching coming off of the left ventricle, and the small pulmonary artery right here coming from the right ventricle. You can also see in this view that that septum is completely intact. Here's another view showing the abnormalities here and showing really that there's only one artery, and that happens to be the aorta. Here's another view, no septal defect here, a very hypoplastic right ventricle. So you can see this is really a problem with the body of the ventricle and then the normal left ventricle. And here's a picture of the cyanotic ductus. This is the aortic arch curving around, and this little red flame here indicates flow through the ductus from the aorta into the branched pulmonary arteries. So pulmonary atresia and intact septum can also present a little bit later in gestation or be more evident later in gestation. Here's a picture showing the tricuspid valve here, the small right ventricle. It's not very, the body is quite hypoplastic, but the annulus of the tricuspid valve looks really quite normal. And then there's a little bit of tricuspid insufficiency here. This is flow out the aorta here. Here's another patient showing the good-sized left ventricle, the very hypoplastic RV, severely hypertrophied and with a decreased cavity here. And then another picture showing again the normal tricuspid annulus size and hypoplasia of the body with the very thick right ventricle. Dr. Puchalski spoke earlier about the coronary circulation in pulmonary atresia and intact septum, and this is probably the most important reason why, as you're diagnosing congenital heart disease in the fetus, it's really important to differentiate tricuspid atresia from pulmonary atresia and intact septum, because tricuspid atresia has an excellent prognosis. Pulmonary atresia and intact septum is very guarded due to the coronary abnormalities. And there is no group of congenitally malformed hearts where understanding the very peculiar coronary circulation has more impact on the ultimate prognosis. So these coronary anomalies can occur in a third to 3/4 of patients with pulmonary atresia and intact septum, and we call them ventriculo-coronary connections, either sinusoids or fistulas or right ventricular coronary artery connections. And these, what happens when you have the right ventricular coronary connections is oftentimes the coronary arteries don't even go back to the aorta, they just stay in the right ventricle. So the treatment for this is not a shunt and not a Fontan procedure, but actually transplant. And it's very important to be able to distinguish these in utero for your counseling, and also to be sure that patients have a cardiac catheterization after birth before the management is decided upon. This was a fetus, a fairly early fetus that had pronounced coronary abnormalities. We see here the abnormal retrograde systolic flow in the right and left coronary arteries that can go to the ascending aorta. These are some of the other findings you can see. Abnormal flow between the right ventricular cavity and the right ventricular myocardium, so it goes from inside to out. And you can have dilated main coronary arteries. This is the Doppler flow from this patient showing the diastolic antegrade flow and the systolic retrograde flow. This is a aortic angiogram here showing the normal coronary arteries, the right coming from the right sinus and the left coming from the left and dividing into the LAD and the circumflex. And this is a picture of a patient with pulmonary atresia and intact septum. This is not a aortogram, this is a right ventriculogram. And what you see is when you inject in the ventricles, flow is going from the ventricle up into the up through the myocardium and never really completely joins the aorta. So this is a very, very serious problem, and we can only really treat it by transplant. So here are some other examples of what the coronary abnormalities look like, again with the flow pattern. Here's another one that you can see the flow in the coronary artery right here and here. So it's a very, very significant disease, and again, really should be differentiated from tricuspid atresia. The classic single ventricle, when we talk about single ventricles, is a double inlet left ventricle with a small outlet chamber and a bulboventricular foramen. This is also a relatively uncommon problem. Usually the pulmonary artery comes from the left ventricle and the aorta comes from the right ventricle in an L-loop form, but the pulmonary artery can also come from the small outlet chamber, so the vessels are normally related, and that goes by the eponym of a Holmes heart. So you'll impress your pediatric cardiologist if you call them up and say, I think I have a fetus with a Holmes heart. They'll probably have to look it up. So here's some examples of double inlet left ventricle here. We see the two AV valves here. We see the good-sized pulmonary artery coming from the larger of the chambers. Here's another view showing the pulmonary artery coming from that larger chamber here. And you see how you can actually make it look fairly normal if you look in this view, but this is the bulboventricular foramen here and the small outlet chamber. And then this is the pulmonary artery and this is the aorta here. I think you can see it very well here, showing the aorta coming from this small outlet chamber. So we talked a little bit about the cyanotic congenital heart disease. Let's look at systemic obstruction. So single ventricles with systemic obstruction. And common to all of these patients are going to be retrograde flow in the transverse aortic arch. So here we see the retrograde flow, right? The little icon is up here, so this should all be blue. And what we're instead seeing is red flow here in the transverse arch. Hypoplastic left heart syndrome was already discussed by Dr. Turetsky, but again, the prevalence is more common actually than hypoplastic right heart, the tricuspid atresia and pulmonary atresia intact septum. There is a fairly high proportion of non-cardiac anomalies, including Turner syndrome, but there are also other genetic abnormalities. There's a 4-fold odds ratio of being small for gestational age, just like the right ventricular hypoplasias. And interestingly, almost a 5-fold odds ratio of a first-degree relative with some degree of left ventricular outflow tract obstruction. So when people come to you after having a baby with hypoplastic left heart, you can't really tell them that the likelihood of having another baby is very small. In fact, it has one of the greatest recurrence rates of all the congenital heart diseases. It's not always the same defect. Sometimes it can be as mild as a bicuspid aortic valve, sometimes a coarctation, but it can also be another hypoplast. There's equal distribution among Caucasians and non-Caucasians, and there's a slight male predominance. So you can see it very early, just like you can see tricuspid atresia and pulmonary atresia very early. And sometimes it's fairly subtle. That is, you can count 2 ventricles, but if you look carefully at the right ventricle compared to the left ventricle, you can see the endocardiofibroelastosis in the mitral valve and also around the free wall of the left ventricle. You can also see that the color flow does not come into this ventricle normally, while it comes into the right ventricle normally, and that's a very good test. So if hypoplastic left heart at 26 to 32 weeks can present like this, with a left ventricle that just hasn't really grown very well and certainly doesn't make up the apex. Looking at color flow, again, because the pressure in this left ventricle is so high because it's dysfunctional and obstructed, you're not going to get normal inflow. Another reason not to get normal inflow is that you might have mitral atresia. Just another picture showing the variance, very, very bright and small ventricle here. And then showing the abnormal flow in this 3-vessel view. This is the pulmonary artery here, and this is the aorta, showing the reverse flow in the transverse arch. Hypoplastic left heart and intact atrial septum is something to be reckoned with. It has a very high mortality rate. Even with in utero decompression, the mortality rate is still about 50%, not necessarily in utero, but after birth. So you can imagine that when you have no mitral valve here, that the only way that blood can get from the pulmonary veins to the rest of the heart is through the patent foramen. It's very hard to look at the foramen and the atrial septum and diagnose intact septum, although sometimes you can because the septum is quite thick. Instead, we rely on the flow patterns within the pulmonary veins. This is a normal pulmonary venous Doppler. This is the S wave, the D wave, and the reverse flow during atrial systole, and that's always present. If you have an intact septum, however, you'll just get to and fro flow, as you see here, because the blood just basically goes in between from the left atrium into the pulmonary veins and reversed. So this is a patient with an intact septum. You can see the pulmonary venous flow here. You can see this is bulging into the right side. Here's another picture. Again, very, very thick and abnormal septum here. Here's the little mitral valve, and here's the little left ventricle here. So it's very important that you distinguish that, because without an atrial septal defect of some sort, these babies are born, pulmonary blood flow increases, has nowhere to go, and the babies can succumb within half an hour. Just some nice pictures of, is it a hypoplast or coarct? And I think that's always one of the dilemmas we see. But Dr. Turetsky's description of the long and slender versus the short and stout is a good way to differentiate between those. So this is a patient who underwent aortic stenosis with in utero valvuloplasty. This is at 24 weeks here, and you can see that the left ventricle is quite dilated. You can see that there's some mitral insufficiency, and the function is very, very poor. There is some retrograde flow, as you see here in the transverse aortic arch. And looking at the short axis view, you see how poor the function is. This patient went to Boston for a valvuloplasty, and you can see the function is a little bit better here. There's still some MR. And you can see movement of the aortic valve, but you see the turbulence in the left ventricular outflow tract. So another type of single ventricle, which was touched on briefly, was the unbalanced AV septal defect. This is a diagram of a complete and balanced AV septal defect, meaning that the right side is as big as the left side. And when you have a complete AV canal defect, you have the primum ASD, seen here, the inlet VSD, seen here, and the common AV valve with 5 leaflets. And patients with complete AV canal have ASD and VSD physiology. We know that sometimes an AV canal defect can appear balanced, but then become unbalanced. This was a nice paper from the people in Washington at Children's National that showed the fate of patients with questionable ventricular dominance, that is a possible unbalanced AV canal, and what happened to them. And I recommend it very highly. AV canal defects are also seen commonly in heterotaxy. 90% of patients with right atrial isomerism will have an AV canal defect, and 50% of those with left atrial isomerism. This is a wonderful quote that for many years I heard from Dr. Silverman, and only later did he admit that it was not his quote, but rather it came from Julian Hoffman, who said the number of cases of right atrial isomerism that do not have a univentricular atrioventricular connection, obstructed total anomalous pulmonary venous return, pulmonary atresia, and transposition can be counted on the fingers of a very mutilated hand. So when you see an unbalanced AVSD, think heterotaxy, chromosome abnormalities. Of course, the most common is trisomy 21, and then least common is going to be normal chromosomes. So you can have a left or a right dominant AV canal. This happens to be a left dominant AV canal, and you can see why. Here's the little right ventricle here, here's the big left ventricle, and the clue is going to be in how the AV valve opens. When this common AV valve opens, it almost totally obstructs the VSD, preventing blood flow from getting in the small ventricle. And of course, where blood flows, the heart will grow. If blood can't get there, the heart is less likely to flow. All right, when 2 ventricles don't equal a biventricular repair, one example would be a double outlet right ventricle with an uncommitted VSD. And an uncommitted VSD just means it's not committed to either of the arteries, so it's usually lower down. And in those cases, the left ventricle usually is quite small, and a biventricular repair cannot occur. And I think those are really difficult when you're trying to counsel patients. Here's a double outlet right ventricle with mitral atresia. Here you can see the tricuspid valve here, the big right ventricle, no mitral valve here, and the small left ventricle. And then when we look at the great vessels, we see that both of them are coming from the right ventricle. Ebstein's anomaly of the tricuspid valve, if it's very severe, the right ventricle is excluded from the systemic circulation, and a Fontan procedure is ultimately performed. So this is a fetus with Ebstein's and tachycardia. This is the AV ring here, but not the valve. The valve is actually way down here. So all this is the atrium and the atrialized right ventricle. This is another patient with Ebstein's anomaly, and the tricuspid valve is way down here. This is right atrium and right ventricle, which is very hypoplastic. And lastly, if you have severe dysfunction, such as in this patient with critical aortic stenosis, you can see the aortic valve here. The right ventricle is working as well as it can, but the left ventricle is not. A patient like this would never be a candidate really for a biventricular repair, and is probably most likely a candidate only for transplantation. So thank you very much. I know this was a little bit of a hodgepodge, but I think we covered the high points. And I always, at the end of my talks, like to thank the sonographers who captured all these images and did such a good job, Mary Maddox and Ricky Brooks from Chicago, and then the 3 fetal echo techs I work with in Colorado, Dawn Park, Lisa Gilbert, and Janine Brunwald. Thank you.